Good evening, everyone. This is Dr. Bill Tullo, Medical Director at Oculus USA, and thank you for attending our webinar tonight with Dr. Yuri McKee, screening high-order aberrations using the Pentacam for your Premium IOL patients. A little bit of housekeeping. If you have questions, please enter them into the chat area, and we'll be happy to spend some time afterwards answering any questions you have. I'm really excited about tonight's webinar. Dr. Yuri McKee is a board-certified ophthalmic surgeon with fellowship training in corneal and refractive surgery. His clinical and surgical training in corneal disease, complex anterior segment surgery, and refractive surgery was completed at the renowned Emory Eye Clinic in Atlanta, Georgia. Dr. McKee specializes in advanced corneal transplant techniques, premium cataract surgery, anterior segment reconstruction, glaucoma surgery, and refractive surgery. He's authored peer-reviewed articles on corneal transplant and repair of dislocated IOLs and numerous chapters in textbooks. He served as executive editor for 3 textbooks on advanced ophthalmic surgery. Dr. McKee has also lectured around the world at international meetings regarding these topics. With no further ado, I want to introduce Dr. Yuri McKee. Take it away.
Thanks so much, Bill. Glad to be here. I'm going to talk to you today about some higher order aberrations and what the Pentacam can do to help you understand these. Now, I want you to realize that there's a lot that goes into this, and I'm really focusing on the higher order aberrations for this talk. So I don't want to exclude anything important just so I didn't talk about it. Remember that there's a really big picture you're looking at when you're considering these patients. But let's go ahead and I'll show you my disclosures there. Let's start with some definitions that are going to be very important for this talk. The first one is spherical aberration. So this is an imbalance of the keratometric power of the cornea between the central and peripheral cornea within the visual axis. This is defined in a 6 millimeter zone. All higher order aberrations are defined in the 6 millimeter zone. The coma is an imbalance in the keratometric power in this zone vertically or horizontally with respect to the center of the visual axis. And I'm going to show you several examples of this. There's an entire tree of higher order aberrations. You only need to realize that spherical aberration and coma are the ones that are visually significant in the 6 millimeter central visual axis. If you're looking at higher order aberrations outside the 6 millimeter zone, you're not looking at what the standard definition for higher order aberrations is, and we all need to speak the same language to understand what we're talking about. And what I want to do tonight is demonstrate this with different case studies. That's it. I try to minimize the words and maximize the pictures on my slides. So this was someone who came in for a cataract consult, no prior surgery. They basically have a plain old refractive situation at the time being, and they were told that they were a multifocal candidate, and they want to know, is that true? Well, let's take a look at the holiday report on the Pentacam. This is kind of the main screen, if you will, for when you look at a refractive cataract patient, and it's going to show us our axial curvature, our corneal thickness, the front and back elevation, relative pachymetry, and then the tangential curvature. But really important, look at the small box in the middle at the top where it says equivalent K readings. And it's going to give us some really interesting information. First of all, the equivalent K readings, which I'm going to talk a little bit more about. But then it also has a little box that says radii ratio B/F, back to front. This is the Gull-Strand ratio. And every patient I operate on, I look at the Gull-Strand ratio. Because if it's not normal, something's wrong, and your IOL calculation formulas are not going to apply properly with an abnormal Gull-Strand ratio. Now, 84% is essentially normal. This person says they've never had cataract surgery before, and the axial curvature map looks fairly normal. There's minimal astigmatism in this case. I guess everything looks good for a multifocal lens. I also look at this and show patients this screen. And the reason I show them this is look down in the lower left-hand corner. It says distribution of the EKR in the actual zone. They're showing a distribution of different keratometric powers measured for this cornea. And what we have here is a very tall, narrow peak. So the correct answer for what's the true power of this cornea lies somewhere in a narrow zone that's being identified here. And I have a high degree of confidence that we're going to find the correct keratometric value so that we can choose the correct IOL power. If you can't choose the correct IOL power, forget about a premium lens. Why pay for a refractive miss? You have to have high confidence you're going to get the correct IOL power with the correct keratometric readings. Now here is the higher order aberration profile for this patient. And I want you to look down where it says n equals 3 and n equals 4 down that pyramid, and then scan to the center. And right in the middle there's two pictures in the middle for n equals 3. That's coma. And there's one picture in the middle of 5 and n equals 4. That's spherical aberration. And here you can see that all those numbers are very low, very close to 0. That's ideal. In general, don't quote me on this, your spherical aberration should be less than 1/2 a micron, and your coma should be less than 1/3 of a micron, all other things considered. So as far as I can tell, I don't see any contraindications for a multifocal IOL in this patient so far. Oh, here's the other eye. Now it gets interesting. I'm not going to define this as keratoconus. I'd have to look at the Bell and Ambrosia curves, which is, of course, a very useful page in the Pentacam, but I don't want to get distracted in this talk about the higher order aberrations or whether this is keratoconus or not. But I do notice that there's a big difference in that axial curvature in the upper left corner there that says, look, there's a big difference in keratometric powers in the visual axis between the bottom and the top of this cornea. I can tell there's coma in this cornea, and I haven't even seen the higher order aberration profile yet. If we look at the Gallstrand ratio up in the box at the very top in the middle where it says radii ratio back to front, 83.9, that's normal. Doesn't show any hot spot in pachymetry, but there is something going on with this cornea. Now, when we go to the EKR value, and again, look at the lower box actual zone, instead of a high narrow peak, I have a broad distribution of potential corneal powers. I like to show this to patients and say, well, one of these is correct. Could you help me decide which one so I don't have a refractive miss in your case? Oh, I don't know. Your idea is as good as mine. I'm like, exactly. So here we are with a low probability of nailing exactly what the true keratometric power of this cornea is. And therefore, I start to wonder, maybe I shouldn't put a multifocal lens in if I'm not sure I'm going to hit my refractive target. And on the higher order analysis, go down to n equals 3, third order aberration, look over 2, and you'll see a minus 0.835. That's vertical coma. That's very high. This is a no-go for a multifocal lens. Patients with multifocal lenses and corneas are not happy when they have all this coma. So this patient, I told, no, the recommendation for a multifocal lens in your case is not appropriate. You look a little deeper than the surface, placido disc topography, and you're going to find a lot of reasons why people would be unhappy. And half of these patients that we see who are unhappy after prior cataract surgery who have these multifocal lenses placed had very clearly identifiable problems before surgery that meant they should have never had it placed. And that's very hard to explain to someone without, bad-mouthing the referring surgeon. I don't want to bad-mouth any referring surgeons, but I do point out, yes, this coma is the reason you're not seeing well, and it's never going to see well with a multifocal lens under it. Let's go to the next case, a cataract patient. They had LASIK in 1995, so early generation LASIK, unsure, but they think they were nearsighted prior to LASIK. And funny how we forget if we were nearsighted or farsighted so long ago. So here is the holiday report. When I look at that axial curvature up in the upper left-hand corner, it doesn't jump out as prior myopic LASIK right away. And the Gallstrand ratio is normal. Remember, in myopic LASIK or PRK, the Gallstrand ratio should be low, less than 80%. This is right on normal. That's interesting. Cornea, 568 microns, not terribly thin for someone who's had LASIK, unless they started really thick. And not a big elevation change anywhere. So do they just have LASIK in one eye? Well, when you look at the EKR detail, I want to call your attention to two things here. Number one, on the bottom left-hand side, the distribution of the EKR in the actual zone, it's a short, wide curve there. This happens in refractive surgery. It happens in many other things too, but it happens in refractive surgery. So I'm starting to think they did have LASIK. And then if you look at the equivalent K reading power distribution suddenly it becomes clear there's a small, very small central flat zone, and that is consistent with early generation myopic lasers that have a very small central zone. So that looks more like LASIK than the actual axial curvature. And I'm starting to think, yeah, there was LASIK, but it was so small and so central, it didn't affect the Gull-Strand ratio. Now, when we look at the higher order aberrations, again, right in the middle of the curve there, n equals 3 for the middle two and n equals 4 for the very middle one. Now you see something interesting. The spherical aberration is above 1/3 of a diopter. It's closer to 1/2. That's on the high end of normal. It suggests that there may have been prior myopic LASIK, even though the Gull-Strand ratio doesn't. So what happens here is the spherical aberration increases as the curvature of the cornea falls below the best fit sphere, and it increases that number there. So positive spherical aberration, the central cornea is flatter than the best fit sphere, and we're seeing that with this 0.526 number, 1/2 a micron of spherical aberration. That's kind of pushing the limits for a multifocal lens. A normal cornea is about 0.2, 0.3 maybe, not 0.5 and above. And so we have less chance of hitting the refractive target in a post-myopic LASIK patient, and they have spherical aberration, which will degrade image quality. And it's all a game of contrast when you're dealing with the combination of light refracting through the cornea and the lens. And if you have a multifocal lens, which will by definition reduce contrast sensitivity because it's splitting light, and then you have spherical aberration above normal, which will reduce contrast sensitivity, the subtle combination of both of them may indeed cause poor visual quality. And this is why I tend to shy away from multifocal lenses in post-refractive corneas. Here's the left eye of the same patient. It's kind of the same thing, except it's just kind of weird because it's a little steeper in the mid-periphery and then maybe flatter, but not quite sure. And again, the Gull-Strand ratio is 83. It's normal, doesn't suggest prior LASIK. But again, if you look at the EKR power distribution, there's a decentered ablation that's very small and inferior. Now that's a problem, because decentered ablations are going to induce coma. And once again, look at the distribution of keratometric values in the lower left-hand corner. It's wide and kind of multifaceted there. Once again, I show this to the patient. I say, please tell me which keratometric value you'd like me to use in your mathematics. You got to be right or your lens power will be wrong. And right away they say, I'm going to pass in the multifocal lens if you can't tell me the lens power is going to be correct. And if we look at the higher order aberration here, this is an interesting look at this. Look at the upper left-hand corner, the three-dimensional wavefront aberration total. There are these peaks and valleys that are perpendicular to each other that looks like a mixed astigmatism LASIK profile. So this patient may have had mixed astigmatism, but then look at the coma. Again, that's n equals 3 line, and look at the horizontal coma, and you see 0.487 microns. It's above our cutoff of 0.3. So the coma is evident in the higher order aberration profile because of a slightly decentered, small diameter myopic ablation, which was not uncommon in first generation LASIK. This patient, in my book, is not a multifocal IOL candidate for these reasons. Next case, number 3. Cataract consult, prior myopic LASIK. That doesn't look like myopic LASIK at all. The Gull-Strand ratio is 80%, technically within normal range, but on the low end. 544 microns, the minimum packing, which you see in the upper right-hand box on the top. I thought I'd see a blue lake in the middle of a cornea. This cornea is all weird. There's a lot of little different spots in it there. It's not very smooth. And all of these patients have had a tear film tune-up prior to testing. Well, the peak of the distribution of EKR is at least tall, although somewhat wide at the base. And I'm not getting a lot of data here in the EKR to suggest myopic or hyperopic LASIK. You look at that three-dimensional wavefront aberration cornea, that's got that specific, almost saddle look where it drops off on the right and left-hand side, but on the top and the bottom, you see it pick up. This was probably a mixed astigmatism LASIK ablation profile. Now, coming down and looking at the coma on n equals 3 in the middle there, it's within limits. I could accept both those numbers, and then the n equals 4, it's 0.438. This is one where maybe you'd get away with EDOF versus a true multifocal or a trifocal. EDOF's a little bit more forgiving for spherical aberration and higher order aberrations. So you could convince me, and the patient could convince me maybe that's what they want to do, but I'd proceed with caution. And I tell them that, we're not 100% sure that we're going to get exactly the right lens power. And I do some other evaluations, especially in the Bell and Ambrosia page, to make sure I could do additional refractive surgery on this cornea if needed. Is there enough thickness, and is there any ectasia risk factors that would make me not want to do additional refractive surgery if the lens power wasn't good? But, there's a new refractive lens out there you can charge for, and that's the light adjustable lens. And in any of these cases, I'd be happy to put that, because I can always use the light adjustable lens to push that lens forward and back closer to a plano result if that's what they're looking for. Here's the other eye. Now this looks a little bit more like myopic LASIK in the center, but it's kind of weird in the mid periphery. It looks a little steeper. It's almost like myopic LASIK on top of hyperopic LASIK, but they say they only had it done once. But look at how wide and no dominant peak we have in the distribution of the EKR values. The EKR-65 has the same thing. The distribution of powers looks like a flat flattening of a steeper cornea. So that's kind of unusual there. And again, the Gauss variation was only about 80%. But the coma, 0.499, that's a little high on the horizontal coma there. And then 662 on our spherical aberration. We're drifting into the danger zone. And remember, it's not the individual values that matter. In this case, you have to take in high spherical aberration and horizontal coma. I'm not doing a multifocal lens in this eye. With a gun to my head, I might do an EDOF lens, but I'd probably convince this patient that something like a light adjustable lens is the better way to go, just for vision quality and the possible refractive error we're going to get, because this cornea may not follow the rules that are written for IOL calculations. All right, next case. We're moving right along here. Let me just stop for a second, take a breath. Bill, do we have any interesting questions at this point, maybe of the last two cases or others that you want me to address at this moment?
Sure, Yuri. I think we can have one or two questions that are relevant to the cases we've reviewed so far. Let's see what we have here. Okay. Well, you answered the first question that I have here. It says, how do you differentiate high order aberrations based on pupil size? And I think you commented on it. You fix things at 6 millimeters when you make comparison. Is that correct?
Yes. So higher order aberrations are completely pupil dependent. And when we speak amongst each other as professionals, we have to have a standard language. And so that's a 6 millimeter pupil size. That's the worst case scenario for most patients in the cataract age zone, where their pupil tends to, max out naturally at around 6. So we're talking about how bad would your vision be at night with car headlights coming at you, and what complaints would you have in that situation? And so the other thing is that sometimes you see these higher order aberrations that are kind of borderline. You can change the aperture size within the Pentacam and see what would the higher order aberrations be in a smaller pupil size, and you'll see it'll get smaller quickly. In that case, you might make the excuse that you're going to maybe proceed on a borderline case because you know that they never drive at night and their pupil's always smaller. But in general, when we're speaking, we have to speak the same language. It's a 6 millimeter aperture or pupil size for higher order aberrations.
I have one more question that you actually covered also, but I think it's worth repeating. And the question is, are high order aberrations an important consideration for EDOF IOLs as much as they are for trifocal diffractive IOLs? And I think, although you did give us your opinion, I think that's an important one and worth repeating. Yeah.
So EDOF is a little bit more forgiving, and so you can get away with some borderline cases. The key here is patient education. You promise someone the moon, you don't deliver, you never could have, and they're not happy with you. But show them the tests, involve them in the interpretation of the test. I even do the IOL calculations right in front of the patient. I tell them these are the odds of what we're going to come up with. And the best mathematicians in the world, for example, the guy I share an office with, Warren Hill, can solidly hit in the mid 70 percentile on predicting the correct IOL power after refractive surgery. So if you're as good as Warren Hill, you can offer someone a 70% chance of getting the right lens power after refractive surgery. And if you're not, you're lower than that. And I tell people that. I sit with this guy every day and I absorb knowledge left and right, but I'm still not as smart as him. And so do you want to pay me a couple $1,000s for these lenses when I can only guarantee you at best a 70 to 75% chance of hitting the refractive target? And so, if you're not a good LASIK candidate to touch things up, then we have to have a lens that's more forgiving. And so EDOF is a little more forgiving, but it's not a get out of jail free card. It's still not as good as a monofocal in terms of handling spherical aberration and coma.
Excellent. Let's save some questions for after a few more cases, so I'll let you proceed.
Sure. All right. Case 4, another cataract consult. They've had RK. And so you can see that. Look at the gold strand ratio here, 100%. So the radius ratio back to front is identical, right? The back of the cornea curve is the same as the front. That's not how it should be, but that's what happens with the central flattening with RK. And look at these Ks down in 29, 30, yikes, okay? And 475 micron cornea, so thinning there for sure. So yeah, I can tell you right now, I'm not going to do a multifocal lens, and this cornea is just irregular. And look at the distribution of EKR. It's wide at the base. There is one peak, but don't be fooled. It doesn't necessarily mean that. The EKR-65 is a great number. The EKR-65 mean, remember that when you look at the EKR-65 mean, it's at a certain zone defined, and usually it's 4.5 millimeters, presumed to be the average pupil size. But for different pupil sizes, you can get a different number. But you can use that as your mean keratometric value with the Holiday number. It's just one different way, and Jack Holiday can explain it better than I can about how he uses that in post-refractive eyes, or in unusual eyes where it's hard to get a good keratometric reading, like in keratoconus, which I'll talk about later. Higher order aberrations, 1.63 microns of spherical aberration. Please do not put a multifocal lens in this patient. I mean, look at, I'm going back a slide here. It looks like we got pretty regular astigmatism in the central cornea. I can, lay the credit card across both the steep and flat meridian. And shouldn't I just use a toric multifocal? No, it's not going to be made up for by 1.36 microns of spherical aberration. The contrast loss from that is way too much, and it's going to cause trouble. Here's the other eye, 29.4 in the lowest K, very flat centrally. You can't really define the strong or weak meridian and the keratometric power here. So you're not going to do a multifocal lens in one eye and not the other. The gold strand ratio is 96%. And I would challenge any of the listeners tonight. I would challenge any other physician. I would challenge the patient. Look at the distribution of keratometric powers in the EKR zone, and please tell me the correct one to choose. It's a low flat curve. Which one's right? Which one's going to give me the correct lens power to make this patient glasses free, because that's what they're paying for with a specialized EDOF or multifocal IOL. And you just simply don't have the mathematical certainty to get the right lens power. So irregardless of any high order aberrations, the basics of getting the right lens power is very difficult. It's about 65% in the best of hands, like i.e. Warren Hill, at choosing the best lens power. And here on the higher order aberrations, look right in the dead center of this pyramid, n equals 4. In the middle picture, 2.132 microns of spherical aberration, 1.2 microns of coma. These numbers are massive. They will not do well with any type of diffractive, multifocal, trifocal, EDOF, any of that stuff. So which lenses should we use then in these weird cases? Well, the Alcon SA60 AT has positive spherical aberration of about 0.19. It's very important to point out that's for the average power lens, and it is power dependent. So the higher the power of the lens, the more the positive spherical aberration. For almost all these cases, the corneal spherical aberration was too high. Please don't add to it with the SA60 AT. I've seen a number of patients where surgery looked perfectly done and the refraction was plano, and they walk in terribly unhappy, and I ask them about, is this your image quality? And I show them a spherical aberration, distorted image, and they go, that's exactly what I'm seeing. I'm like, yep, that's because you have this positive spherical aberration lens on top of positive spherical aberration in the eye, and it messes everything up. The times you should put an SA60 AT in the eye are so far and few between. I think I've done one in my career. Just don't use positive SA lenses, especially in these cases. Now, in the two cases I just showed you, especially the last one with the radial keratotomy with a lot of aberration, over a micron, just massive amounts of aberration there in both coma and spherical aberration. A neutral SA lens is probably your best. The Envista, or the Li61 from Bosch and Lohm are neutral spherical aberrations. There's a few other ones out there. I believe a HOA has one. The negative SA lenses, which are very popular, like the Alcon and the J&J, these are very popular lens brands out there. They have a little bit of negative spherical aberration to counteract the normal positive spherical aberration of the cornea. And these are not going to fix a micron of spherical aberration. They're not going to make much difference, but they are going to induce other types of aberrations into the system, which are harder to tease everything out. So my preference with highly aberrated corneas is a neutral spherical aberration IOL to try to limit the aberration I'm putting into the system. I used to kind of try to mix and match the negative SA lenses like the Technis and the Acrosoft, but I just don't do it anymore. And once again, these values I'm giving you are for the middle of the IOL power curve. They get worse as the power increases. All right, I want to change gears for a second here. I've given this talk before. There's actually a separate talk just for a few minutes here. It's just really important to understand this, and I still get questions about it, so I'm going to talk about this again. There is a huge utility in the EKR-65 for abnormal corneas and trying to understand what's the overall keratometric power. It's one of the best tools out there that we have, especially in keratoconus. So if you see a patient with keratoconus, do not take standard lens star or IOL master measurements and then apply them to the Barrett or the Hill RBF and then think you're going to come out okay. You're going to get a hyperopic result. You're going to get unpredictable results. And let me show you how that works. In this example, I had a female physician come in. She had keratoconus. She had significant cataracts. I had her cross-linked. This was back in 2020. She still showed stability, even some flattening over 7 months, which I documented with the Pentacam progression analysis. She wanted to be myopic. She wanted to be able to read without glasses. She was used to that being a keratoconic patient. And I'm just going to show you all these different measurements I got. So here's your basic Pentacam measurement, and you can see she has, steepening inferiorly and about 4 diopters of astigmatism. She got cross-linked. There's before and after regression pictures showing that, if anything, she's flattening, but certainly stable. And here is the distribution in the EKR zone. You can see it's a broad, double peak here. We don't know what her true corneal power is because the sampling of an IOL master or a lens star are small central autokeratometry where you can sample across a steep and a flat zone within that in a keratoconus and get really unusual measurements that fool what's going on, where the EKR-65 is taking the 65% mean of the powers in a certain zone and not being fooled by a little shoulder where you could measure the top and the bottom and find a big difference that doesn't really exist. So I got all these different biometers. I got a lens star, I got an IOL master, I got a Pentacam. We're doing all these different tests. The axial length is not the challenge here. The challenge is the keratometry. And let me just show you here. I've kind of put all this together. The Cassini is up there, the Atlas is up there. Never use Atlas sim case for keratometric value. That's not what they're designed to do. They will hurt you if you do that. But I put them up there to show you the average K on the Atlas sim case was 44.6. For the Cassini, it was 45.7. For the Pentacam regular sim case, it was 43.4. The lens star was 44, but the EKR-65 was 42.9. So everything is overestimating the power of the cornea except the EKR-65. So if the EKR-65 is correct, then the keratometry of all the other devices will overestimate by 0.5 to 2.6 diopters. This will lead to a hyperopic result of about a diopter if I just use, for example, lens star case. And this is the well-known problem with doing keratoconus eyes is people say, well, just aim for -2 because then you won't be hyperopic. Well, what if they want a specific result? We got to do a little bit better than just a fudge like that. Well, I use the EKR-65, and so you can see up there in the upper right corner where I put the red EKR-65 value was 42.89. Plug that in as her keratometric values, aim for -2. The predicted was -2.11 with the 25.5 diopter lens I used. She came out -2 2.3. That's a 0.2 diopter difference. I defy anyone to do better. And I've got several cases like this. So basically, you got to be careful with keratoconus. And one of the best ways to not get burned in a hyperopic surprise is to use the EKR-65 for your keratometric power of your cornea. It prevents hyperopic surprise. The other way to do it is use the Barrett calculator, which can use normal keratometric values from, say, a Lenstar or an OWL Master, and then it makes some adjustments and lookup tables for that. But my personal favorite is the EKR-65. You can see it does a nice job of avoiding hyperopia. As a matter of fact, it's slightly myopic in its result compared to normal. We've seen this over several cases where it is ever so slightly myopic, which that's fine. I'll take that. And these keratoconus patients, they're used to that. So for the EKR-65 keratometric values, low refractiveness in keratoconus, I would have had a hyperopic result otherwise. No other means was more accurate in measuring keratometry as the EKR-65 in a keratoconic cornea. So, well, Bill, I'll give the screen back to you. That's my presentation. That's a lot of data. You know, I hope you weren't taking notes. I hope you're just enjoying these different cases and kind of picking up different bits and pieces about just some specific things, just looking at the higher order aberrations and how they can help you. Remember, there's a huge picture. You have to look at the exam. You have to look at prior records. You have to look at their refraction. You have to look at multiple topographers. But at the heart of all this, where I'm getting my most data to help these patients, is the Pentacam with the numerous different screens I can look at to really learn about these corneas and help these people get the refractive outcome that they want. And I think you see I'm a little bit biased against multifocal or EDOF because in almost every one of these cases, there was something higher order aberration-wise or refractive, result-wise that would have precluded a likely successful outcome. Now, in normal eyes, when you look at all this and all the stars align, I feel really good about these advanced IOLs. But in unusual eyes, this just is the, data I need to show patients and other surgeons, maybe that's not the smartest thing to do. You're rolling the dice and if they're going to have a good outcome or not. Bill, back to you.
Fantastic, Yuri. I really love looking at real live cases and looking at the outcomes and looking at your logic that you use to arrive at these outcomes for patients. I've got a couple other good questions I wanted to ask you. One was getting back to, you're talking about back-front ratio and utilizing that to determine whether a patient may have had myopic or hyperopic refractive corneal procedure. The question is when trying to determine the hyperopic versus myopic ablation, how accurate or helpful is the refractive change box in the holiday report at the upper right? So do you look at that at all, or do you just really look at the back front ratio?
No, the Gulf-Strand ratio is the most important thing. And just as a reminder, myopic LASIK or PRK, you're going to see, less than 80% usually. And then hyperopic refraction ablations, you're going to see above 85 usually. But when you get up into the 90s or 100s, then you're talking RK. So the interesting thing is RK was designed to treat myopia. Yeah, it's going to do the opposite of LASIK. So just keep those things in mind. I think there's so much good stuff on the Pentacam. It's almost overwhelming. And to answer some of these questions, it's going to take Jack Holliday, because he's the one who came up with so much of this stuff about the importance of different factors that he's put on there. And I might sound smart, but I'm barely scratching the surface on this device. It'll take me the rest of my career to really understand all the cool things it can do. I think one of the things that is a little sad is that we pay a lot of money for super fancy devices, and we barely scratch the surface on what they can really do. And there's all these crazy smart engineers around the world, back in Germany and whatnot, we're building these devices and making these amazingly good functions, but we really got to sit down and learn them to understand and get the full money's worth out of our devices. The Pentacam is a prime example of that. There's reams of data that you have to understand to really get the most out of it. And hopefully a webinar like this is helping people, just like me, scratch the surface and start to go a little deeper than just looking at an axial topography map.
So speaking of scratching the surface, there is another set of parameters that a lot of clinicians utilize, and that's chord mu and chord alpha. Can you comment a little bit on those parameters, and if that's something that you consider when deciding whether a premium IOL would be beneficial for a patient?
I don't use them that much. Warren and I were looking at them and we played with them, and I pulled up the screen here. There on the like the Corneal here is on the upper right-hand box there. Jack can tell you why they're more important and how to integrate them. I just don't use them that much.
Yeah, I think that what's going on right now is there's extensive research being done about normative databases and its impact on various different IOL designs. And I'll be excited in the future when we can introduce those normative databases to give you even more information with the overwhelming amount of information that's already in the Pentacam. But I think you can never have too many normative databases. And that's going to be something that we're going to see in the future for back front ratio, chord mu, chord alpha, all these other parameters that we look at when trying to decide, again, what's safest and best for our patients.
Maybe this is the next thing I look into when you publish those databases, so I can be more knowledgeable about that as well.
Excellent. My last question goes back to your patients with keratoconus and whether or not you decide on putting a toric IOL in their eyes and the potential complications of the oblique cylinders. What do you use as far as your considerations on whether or not you're going to put a toric IOL in, and do you always put a toric IOL in, or are there some reasons or cases where you avoid it?
Yeah, so let me fast forward to the keratoconus case I showed you there. There are 3 rules for placing a toric IOL. The astigmatism is regular, repeatable, and orthogonal. Okay, so obviously regular means that you're balanced between the right and left or up and down side of the steep meridian. And so in this case, we're not. We're largely imbalanced. And then the second one is repeatable. So I can see the same astigmatism that is regular across multiple tests. And then the third one is orthogonal. So is the true steep meridian 90 degrees away from the flat meridian? And in keratoconus, you're breaking 2 of those rules. Now, sometimes we get kind of good enough astigmatism that we think that at least the toric lens will reduce the amount of astigmatism functionally for this patient in a good way. Well, do they want to burn their hard contact lens bridge, or do they want their best quality vision? In any case, a hard contact lens over an irregular cornea will always give your best quality of vision, but you burn that bridge if you put internal astigmatism into the eye in the form of a toric lens or even a light adjustable lens. So if someone swears to me that they're done with hard contacts, come hell or high water, and then I just kind of have a gut check, like, look, does it look like I can make it work? I'd say this example right here, I'm not going to make it work. It's too irregular. So I wouldn't put a toric in. But there are cases of keratoconus where it is balanced enough without too much coma that I say maybe I can make this work. It's a bit of an experience thing, and you are kind of riding a fine line. But I have seen corneas somewhat normalize after cross-linking, so I tend to cross-link people before we consider cataract surgery and let them normalize for 6 to 8 months, maybe a year, and then come back and reconsider. But regular, repeatable, and orthogonal are the rules you have to follow for a toric lens, and 2 or 3 of those rules are almost always broken with keratoconus. When you start breaking rules, you're rolling the dice on outcomes.
And I will double down on what you said. Some of the most difficult contact lens fits I've ever had to do optically was post-keratoconus, post-toric IOL implant. Trying to get them back to a reasonable best corrected vision can be almost impossible. So I totally agree with what you said there, and I think sometimes those rules are not always followed. So we have one more last-minute question here, which I think is worth clarifying. And that is when you're talking about ocular corneal aberrations or whole eye aberrations. So you're just considering the corneal HOAs or the whole eye HOAs?
Well, there's a couple different ways to get entire eye higher order aberrations. One is a staphyloma or some type of irregularity in the retina, which you should have diagnosed in your workup. And then the other one is aberrations within the natural lens, which we are by default removing in cataract surgery, which is kind of what this talk is about. So really what we want to do is understand the impact of the cornea, because that's the main refractive surface that we have to interact with our intraocular lens. And I'm assuming that the retina is normal in these cases. Of course, I'm going to double check it. But for the purposes of this talk, we're going to assume there was no pathology in the retina, like a weird staphyloma, which could cause some unusual things. Those things are pretty unusual. So primarily, we're looking at corneal aberrations when we're looking at refractive cataract surgery.
Okay, so I lied. I've got one more last-minute question. It just came in that I think is worth clarifying. Is that, Yuri, when you use the EK-65K readings, what IOL formula are you inserting them into? So, and I know that's going to depend, but yeah, I'll let you answer.
Use Holiday. That's what it's designed to do. I've used it successfully with the basic Barrett formula. You want to be a little careful because EKR-65 takes into account some posterior corneal power, and so does Barrett. I always do multiple formulas. I do Hill, I do Barrett. I can even do the Holiday one, which is still a great formula. And you know, when you look at the difference in accuracy between Holiday 1 and Hill or Barrett, well, they're obviously better when they're newer generation formulas, but the noise of the system when you have an irregular cornea far outweighs the differences in performance of IOL power calculation methods. And as I've said before, bad data cannot be made up for in good IOL power calculation methods. You have to have good data to put into any power calculation method. So, you know, I tend to back check everything to Holiday 1 in these irregular corneas and just tell people, we're not aiming for a home run. We're just getting this thing in the ballpark. I just don't want to strike out here.
Yeah, I think your point about making sure you don't double dip and use a formula that's already accounting for that back astigmatism is an important one. And all the earlier formulas don't do that. So I think that's the safest bet. But understand the formula you're using. You do not want to put those numbers into a formula that's already taken into account those issues.
Right.
All right, I think we've covered all of our questions. Yuri, I want to thank you so much. I love this talk, and I always learn something every time you give it. So I really appreciate your time tonight, and I appreciate everyone for tuning in tonight. This recording will be available. In about a week, we will send this recording out, and it will also be posted on our YouTube channel. So once again, thank you so much, everyone. Have a great evening.
Thanks.